I'm Julie Schweitzer, as I said earlier, professor in the Department of Psychiatry and Behavioral Sciences and faculty member at the Mind Institute. I have a long interest in attention and impulsivity, and as it unfolds through development, and particularly adulthood, and then I started working with children again, but I have a long history of working with adults as well. I'm grateful tonight to be joined by two of my esteemed colleagues, Dr. Faye Dixon in the front row here, Dr. Murat Pakyurek as well. Okay, so prevalence of ADHD in the community-wide sample is, I think, really important to talk about because we have seen so much interest as evidence here tonight. What we find in a very large sample is that evidence of ADHD, when explored with interviews and rating scales with self-reports, is about 4.4%, okay? Now, what we're also finding is that it's mainly men who are reporting it, who are previously married, unemployed, and non-Hispanic white. They also have a high rate of other psychiatric disorders, not just the ADHD. Women are also more likely to seek help for ADHD, even though they have a lower prevalence of ADHD. And there's lots of functioning that's impacted. There's self-care, but also work. Work is tremendously impacted by ADHD, and that's why I think a lot of people do come into our clinics, is because they're realizing they're having difficulties at work. Now, I frequently get the question, is it just in the United States that we see that ADHD is so prevalent in adults? So this study is a little bit old now, it's from 2008, but you can see here, the US certainly has a fairly high prevalence rate, but there's other countries that are also fairly high as well, including France. I'm not sure what that says about France, but I find that interesting. We find that women is less common, same in adults as we find in children, but we also find that, again, work is very much impacted with about 22 days of work lost due to ADHD-related issues. We also find that people were treated for mental health disorders, but typically not ADHD. Even though they had the ADHD symptoms, they didn't realize the ADHD was impacting them. It was more mental health and substance disorders that were really driving the treatment. This is a fairly new graph here from 2017. And I think this is what a lot of the public is responding to. You can see these rates here, this huge increase, particularly within the past 6 years. So the top line here is rates of office visits for ADHD, and these are office visits accompanied by a prescription for medication. And so this is really, I think, what a lot of people have talked about in the media is this really dramatic increase of recognition of ADHD and people going for treatment. Now, what's interesting about this is when you delve down into it, is that the period of these increases really showed a difference in diagnosis. So in the adult population, what you find is that women were much more likely to seek treatment in adults. But yet in children, it was a different story. So I'm sorry, it's actually the reverse here. Pediatrics, the children, the females were much more likely to seek diagnosis. So medication increased across the board in children and in adults, but much more so for the adult population. Okay, so impact of ADHD. These are some of the very well-known impacts of ADHD. Social behavior, as I mentioned, work behavior, higher rates of accidents, so we see more traffic citations. I'm really concerned about the texting going on because we have people who are very impulsive, so they hear the phone buzz go off, and you combine that impulsivity with inattention, and you get much higher accident rates and citations. We find higher rates of criminality as well. And what we'll talk a little bit more about is, unfortunately, in women in adulthood, we're finding suicidal intention and actually suicidal acts as well. ADHD is unique in that it affects the individual, but it also affects those people in the family constellation. So even for adults with ADHD, we hear parents of adults complaining about the issues that their adult children are causing for the family. It's the same thing again in the work setting. So oftentimes I hear people who are coming into my office and their concern is getting along with their supervisors and getting along with their peers. And this plays out again and again, is that it's not just the individual, it's the family, and eventually it becomes a much broader perspective. I had a wonderful colleague earlier today who videotaped a segment for us for our website about adult ADHD and how she has struggled, but also how she has overcome some of those issues. And she talked about insight and the importance of insight. And that is really, I think, key for so many people with ADHD, is once they gain insight, they see the impact their symptoms have, not just on themselves, but on those in their context as well. So that's a little bit different than a lot of the disorders that we see in adulthood, is this general impact on the family and society. So long-term outcomes. This is still an evolving story. We do know that about 1/3 of people with ADHD seem to have a remission of symptoms. You'll see here, though, this statistic is huge, 5% to nearly 70%. So it really depends how you are diagnosing ADHD and what tools you are using to assess it. So for some people, they continue to have a problem. For some people, about 50% of the problems dissipate. The most notable symptoms, such as the hyperactivity, are really what seem to dissipate over time. Those become much less visible, but you may see people where they're maybe grabbing things, or they're touching things on your desk, or they're fiddling with the remote control, things like that, but they're not physically running around the room. And so some of these symptoms might still be occurring, but they're harder to see. What we're finding, as I said earlier, is that for girls, we're seeing a change in how some of the symptoms emerge. And I'll talk about some more about that, is that the symptoms of emotionality are becoming much more recognized, that they are very impairing. So this difference with development that occurs and the comorbidity that tends to also increase with time is what really needs to also be looked at, and not just the ADHD symptoms in themselves. This is just one study of many looking at educational outcomes, and LNCG essentially means a control group here, and this is ADHD, and these are people who have lost about 50% of their symptoms, and these are people who continue to have many more of the full symptomatology in ADHD. And these are people who are acquiring their bachelor's degree, so you can see, this is a longitudinal study, you can see that there's no comparison. This is the comparison of these two together, that people with ADHD are much less likely to get a bachelor's degree, but those people who have the most severe symptoms, the likelihood that they will obtain a bachelor's degree is greatly diminished. And of course, that affects their income ability as well, right? Now, these are some of the emotional outcomes that I was talking about. So this is looking again at those same groups. LNCG is a control group, ADHD, the black solid bar is a combination of these two. And this is an area we have become particularly interested in my laboratory in looking at. So this is looking at emotional lability. And emotional lability means your ability to control your emotions, or your emotions going up and down, depending on situations and so forth. And then also looking at some mood disorders and anxiety. And what you see overall from the picture here is that people with ADHD have much more severe emotional functioning as they mature. And again, those people who continue to have the ADHD symptoms to a greater degree, the persisters, they have much more difficulty with emotional functioning overall. So that has huge implications for treatment, right? You can't just be looking at the ADHD, you have to be looking at all these other symptoms as well. But also, if you think back to those earlier slides that I showed you, people who had ADHD who were coming in for treatment, what was driving that oftentimes was the emotional behavior, not the ADHD. So it's not that unusual that somebody will come in for help to a psychiatrist or a psychologist who's used to working with adults but not with children, and it will be the emotional symptoms that they're being asked to look at, but really it could be the ADHD that was there all along that could be driving some of these other symptoms. This is an old study of ours that came out in 2011, but this also looked at things like which disorders was much more likely to predict educational outcomes. And this was graduation for high school on time. And what we found is, compared to all these other disorders, the disorders were much likely to be lead to people dropping out of high school, not finishing high school on time, was the ADHD and conduct disorder. Even those with the inattentive type were much less likely to graduate on time. So if we focus more on these disorders, we are more likely to have successful adults. So ADHD we know is controversial, right? Particularly in adulthood. So we have lots of evidence that ADHD is real, but we also have to acknowledge that ADHD can be misdiagnosed. We don't have any biological measure that we can use diagnostically. We can't take a blood sample. We can't do an X-ray. We do brain imaging all the time for our research, but it's not diagnostic. So there's lots of other reasons that somebody can present with some of the symptoms of ADHD, particularly inattention, because inattention we see in almost every other psychiatric disorder. So just because one thinks that they have ADHD and they have problems with impulsivity or inattention doesn't necessarily mean that it is ADHD that is causing the problems. So when one does a diagnosis of ADHD, they need to not just look at the ADHD, but they need to look at what other reasons might be there for causing these other symptoms. And again, you want to do a really good, thorough diagnosis because it could be, even if you do have ADHD, you have the other issues that I was talking about earlier. The other thing to recognize is that ADHD is on a continuum, and the symptoms are. So you can have a degree of ADHD, and in some situations it can be very impairing. I meet lots of people, particularly if they're in a high active field, such as consulting or sales, and they do quite well. Their ADHD symptoms seem to be under control. Then they get in a situation where they get promoted, and they have a desk job and lots of paperwork. And suddenly those ADHD symptoms become much more impairing. They have less flexibility, they have to be on time, their physical activity has to be squashed to some extent, and so forth. So it's important to look at the context because that makes a tremendous difference. And children, they're much more constrained in some ways because they have to be in the classroom. With adults, they have more flexibility, and that can be very helpful to them if they find their niche. But that means that there are times when these symptoms wax and wane, and then that's why sometimes diagnosing it can be a challenge because of those issues. This is a few years ago from the New York Times, but I'm sure many of you heard about this concern about people using medication to increase their performance, particularly on tests. This is a ninth grader who has many of his peers who are apparently using stimulants to try to improve their test performance. But where we're mostly concerned about this is on the college campus. I remember probably in the 1990s when I was a faculty member at Emory University, I had a research assistant telling me that that was a concern back then about students having to lock up their stimulant medication in safes because it was being stolen by other students. We continue to hear about these issues, and we do need to be cognizant of it. And I think it's really important that we do a thorough diagnostic job because there are people who probably really are trying to get the medication to improve their grades. And there are other people who are using it for other reasons, less scholastic, so they're using it to get high and so forth. So one has to be very careful and make sure that they're not just talking to the young adult who's coming in the office for ADHD, but you also need to talk to the parents. But I can tell you, I've had some psychiatrists tell me that they have some concerns that some parents are helping their children fake as well because they want their children to do well on the tests. So that is a concern. And unfortunately, because we don't have any biological tests at this time, one can fake the ADHD symptoms if you just ask them to verbally report. What I like to do is get report cards. I get report cards from elementary school. I have asked people in their 50s and 60s if they have report cards, and a lot of them, it turns out, have parents with attics where they keep them. So that's quite useful. And it's also useful if it says that there were no problems throughout childhood. That's very telling to me. But having some evidence is really critical because we can't just rely on self-report. And I also have people who have come into the office and they really genuinely believe they have ADHD, and the way they report it, it seems to them like these symptoms are really overtaking their lives. So they're genuinely reporting it, but I have to, as a good diagnostician, look at how the extreme these symptoms are, and what they may feel are extreme are really not that severe. So that's where we come in as a professionals. So people may be well-intentioned but still not have ADHD, but they may have something else going on that we can help them with. There's a lot of concern about diversion of stimulants because of the situations that I just discussed. And there are some ongoing studies about that. A lot of it has to do with training with primary care physicians. So I have some colleagues who are doing work in that area, training primary care physicians how you do assess ADHD because of the concern about diversion. So I just want to talk a little bit about the neuroscience area and what our findings have been recently in ADHD and some of our older findings, because a lot of the older ones have held up as well. It's really exciting that there are some very large studies now using brain imaging in ADHD. This is a collaboration that's throughout many countries in Europe, as well as some collaborators in the United States. And in this study, they looked at the structure of brain regions implicated in ADHD. And by structure, I mean the size, the volume of the different brain regions. And these are the regions here. And what they did is they looked at these brain regions that we've seen frequently implicated in childhood ADHD, and then they've measured that in adults. And what this is size of the brain region in comparison to healthy controls. And what you see here, these are all the areas of the brain where there's decreased volume in size. This is one area where there's increased. And what they found was very interesting in that, so the red bar here, the dark red for each one, is if you average all of these different ages together, and then they have children, this is the next bar, and then they have adolescents, and then they have adults. And what they found is that for children, the differences are much stronger compared to adults. Adolescents, in this one area of the brain, the hippocampus, which is related to memory, there's a huge difference in adolescence. It's much smaller, yet in adulthood, it's actually larger. So you're seeing this really fascinating trend that in children with ADHD, these areas of brain structures are much smaller than they are the typical children. But when they become adults, a lot of these brain regions seem to gain in size. And people have talked about this maybe 10 or 15 years ago, but this is replicating at a much, much larger scale. And it suggests that as one matures, these brain regions do increase in size. But I think it's really, really important to remember that brain structure, the size of a brain region, is not the same as how that brain region works. And I like to think of it as if one was listening to a symphony. And as one looks at as a symphony begins to play the notes and the different instruments come in, as different instruments, the violin, the flute, and so forth, join the piece, if they're off, if they join late, that affects completely what the piece sounds like. So if you have pieces that are coming in and they're playing the right notes, but they're playing it at the wrong time, that is completely going to affect how that symphony is going to sound. And I believe that's what's happening in ADHD, is that even though these areas of the brain catch up in terms of size, that doesn't mean that they are working the same way that they would be in a typically developing person without ADHD. And these are some very old data of ours from 2004. This is looking at functioning of the brain in adults. So we gave people a working memory task while they were in a brain scanner. And the NC is normal controls compared to unmedicated ADHD. And these are areas of the brain where typically developing adults had more active brain activity. And these were areas of the brain where the ADHD actually had greater activity. And what we found was many of those same regions that were smaller that you saw in the previous slide, these brain regions were actually more active. It's as if there's some compensation for those regions that are smaller. So that's really, really important. If you see something in the press that says people with ADHD, it'll just resolve in time because we see that the structures of the brain catch up, that doesn't mean that the brain is acting in the same way. I think it's really, really important to understand. Because if that was true, if the brain was acting the same way, we wouldn't have lots of people presenting with ADHD in adulthood, right? It would all disappear naturally over time. So we know that there really is a biological reason for these symptoms, and that even if the brain structure is the same, that doesn't mean the function is the same. What we hope to do in our laboratory is to use a combination of all this information to help us think about better diagnostic tools, but in particular, how we can also help people with ADHD, including doing some prevention. Most of the treatments for ADHD have not been informed by neuroscience. And one thing that I really like about our lab is that we try to take our findings from our brain imaging studies and so forth, and then use those findings to help us think about how we can develop new treatments. The time in terms of development that's most important, I think, is during adolescence, because many of the changes that are most dramatic that occur in brain structure and function is during that adolescent time period. That's a really important window that we can then start thinking about how to design treatments. And most treatments for ADHD are actually designed for children, because that's most frequently when ADHD presents for people between 5 to 9 years of age. But we have this window now during adolescence, and what those treatments are in childhood are not the same as what's going to work with adolescents. Teens are very different than young children. And there's some really exciting work happening right now. Margaret Sibley, who's at Florida International University, and some of her colleagues are looking at how you design treatments to work with adolescents. At this point, most of the treatments are not still taking neuroscience approaches, but that is something that our lab is looking at. Now, along with that, there's a big buzz the past few years about precision treatments and using targeted treatments that go along with the specific symptoms that we see. And our long-term goal is to integrate adolescent teen findings with brain development, and then also look at the specific symptoms. So we might find that some teens have particular problems with attention, while others, the real issue is impulsivity. And for some people, it will be both. Our goal is then to take the symptoms that are occurring, look at where the stage is in terms of their brain functioning, and then find treatments that can specifically work for those individuals. That is a long-term goal that will take quite a while to develop, but we hope to get to that point where we can look at individuals and then design some sort of treatment to help them, because at this point really is trial and error.
What I wanted to talk a little bit about this evening is kind of the neurodevelopmental progression of ADHD, because ADHD is a condition that first gets diagnosed in childhood, but we now certainly understand that for a significant number of people, it will progress into adulthood. So it's really important to understand, kind of what the symptomatology looks like from a very young age into adulthood, and then to begin to understand a little bit about kind of the adult presentation. So certainly at the earliest age periods at which we might diagnose ADHD, in the preschool years, probably somewhere between 4 and 6, the primary characteristics are what we call behavioral disturbance. And essentially what that means is, parents and teachers are saying, this is a kid who is super wiggly, this is a kid who's not sitting still, this is a kid that I can't take into Target because they disappear underneath, the clothing racks. This is a child who is perhaps having difficulty sitting in circle time and listening to the story with other kids. So that's where the presentation first starts. For school-age kids, and when we're talking about school age, we're probably talking about kids kind of between the ages of 6 and 12. For many of them, you can also still see what we call that behavioral disturbance, that wiggliness, that fidgetiness, that activity. But one of the things that begins to kick in at that time frame is academic impairment or academic concerns, because that's when kids are first entering school, learning the basics of, reading, writing, math. And if you're struggling with attention, that might have an impact on how you're, accessing academics within the classroom. We also begin to see, peer issues or peer interaction concerns. By the time kids are 7 or 8, a significant number of kids have an understanding of well, this is how you play a game, this is how you interact with other kids. This is how you do reciprocity, have give and take. And for kids with ADHD, they often struggle with those kinds of same cues. So not because other kids aren't interested in them, but perhaps there is a way in which they are functioning that's making it hard for them to have the same sorts of peer interactions, which then, of course, can lead to other kids saying, I don't think I want you to come to my birthday party. And one of the other things that begins to emerge then at that time is that because of what's happening in the environment and how, kids with ADHD at this age are, either meeting or struggling with the various developmental tasks, is that they can begin to develop what we think of as co-occurring conditions. So that is, kids begin to struggle not only with ADHD and the inattentive or activity symptoms that go along with that, but also begin to struggle with things like anxiety or depression. And then in adolescence, we see some of the same characteristics, the difficulty with academics, in part because there's much more to organize at that age. An adolescent has 5 or 6 different classes, 5 or 6 different teachers, multiple assignments, all competing with one another. And if you're struggling with inattention and organization, that's going to have an impact, or potentially could have an impact on how you're doing in school. Some of the same concerns with peers as, happen at an earlier age. But also one of the things that begins to occur in adolescence is sort of this struggle with how kids are thinking about themselves. Kids are maturing from childhood, sort of moving towards adulthood and getting feedback from peers, from teachers, from parents that perhaps my behavior isn't measuring up in the same way. So for some kids, they begin to develop issues around, self-esteem and, concerns about, how am I doing? And for adolescents, whether we're talking about ADHD or typically developing kids, this is when things come into the environment that pose risks, in terms of risky behaviors. For teens, there are the possibilities to, engage in smoking activity, drug behavior, impulsive decision-making. So those are things that get presented certainly as risk factors for all teens, but are a particular concern perhaps for a child with ADHD who is struggling with inattention, who is struggling with making, impulsive decisions and thinking things through. And then again, the co-occurring conditions such as the anxiety and the depression. And for college-age students with ADHD, what we often see, or one of the things that presents frequently in a clinic setting, is academic failure. And academic failure in kids who are incredibly bright and talented, but because of disorganization, struggles with time management, struggles with prioritization, not being able to function at, an academic capacity that would be, commensurate with where perhaps their cognitive potential is. These are kids who are struggling with, day-to-day activities, particularly, when you're in college. It's up to you when you go to your class, or if you go to your class, or how late you stay up, or what activities, you participate in. And so for kids who have challenges around kind of integrating those kinds of things, they may have difficulty with what's required for them day to day, struggling perhaps with, a part-time job. And again, the issues around, how they're feeling about themselves. And certainly for many college students, difficulties with alcohol or substance use. And then for adults, we really see the struggle around day-to-day activities. Dr. Schweitzer, talked about that these are often bright, capable adults who are struggling with employment issues, certainly unemployment, but often commonly what we call underemployment. And that's somebody who's incredibly, talented, gifted, but working at a position that is perhaps not, commensurate with what they might be able to do if, they could prioritize better, could use their time better, could work, end to end on difficult tasks. We see, relationship difficulties, marital concerns, more motor accidents. And actually, motor accidents are true both for teens and adults. And as Dr. Schweitzer mentioned, that distracted driving, making the impulsive decision to text or not text when it's perhaps not the appropriate time. And certainly concerns around alcohol, substance use, and, mood instability. So some of our diagnostic considerations when we think about adulthood is certainly currently, we need to have an evidence that there was impairment in childhood. There are a couple of researchers out there, Dr. Mary Salanto and Dr. Richard Gallagher, who are actually considering whether or not ADHD can present in adulthood if it hasn't been present in childhood. But currently, we think of ADHD in adulthood as kind of an extension of symptoms that occurred at an earlier developmental age. So we're asking, was there evidence of ADHD in childhood? You need fewer symptoms in adulthood to meet criteria, for ADHD. Do we have evidence that there's substantial impairment, and that impairment is occurring across different settings? Like, is it happening in their school setting if they're in college? Is it happening in their work setting? Is it happening at home? Is it happening across relationships? And we also, as Dr. Schweitzer pointed out earlier, we want to make sure that we've looked at any other explanations that could account for the symptoms, because certainly the core symptoms of inattention and distractibility occur across a whole host of different psychiatric conditions. And we certainly also want to know, if ADHD is present, are there also some co-occurring conditions that would need to be treated at the same time? Just wanted to just say a little bit specifically about, college students, because they're in that young adult phase of ADHD. And 25% of college students who are receiving any kind of disability services have been diagnosed with ADHD. The primary things that they're struggling with are time management and organizational skills. So these are kids who are ending up with a lower GPA and are more likely to be on academic probation, and that's despite, being, very talented and capable. We know that for college students with ADHD, we're seeing increased rates of alcohol, smoking, and drug use. And incidentally, rates of self-reported diagnosis tend to be lower at historically Black universities and colleges. Adults with ADHD often struggle with something that we call executive function. So what is that? So it's really kind of a set of actions or behaviors that kind of help us to, choose, self-control, versus an impulsive action, to kind of be more self-aware. That is, to get the big picture, to be able to use, your own language or speech to kind of talk you through your work, this has been described in research as kind of like self-talk or internalized language, where you're using that as a loop inside your head to help you progress through a particular project. It's also being able to use things like imagery, kind of forming a mental picture in your head of something that you need to do while you're working through the activity at the same time. In research, we call this working memory. And my easiest example of this is that every time I go to the grocery store, which is several times a week, I always forget the grocery list, which means that I'm calling my husband at home saying, read to me what's on the list. And so what I am doing is I am trying to hold online everything that he's telling me while I'm running around and trying to get those things at the same time. And I can just tell you that I always come home missing at least one thing. And also another, piece of that is being able to evaluate how much effort you're going to need to be able to do a task, and to be able to kind of harness that internal motivation to persist from the beginning all the way to the end. And then another piece of that is what we call kind of complex problem solving. That is, sort of gathering data and using all of that in what we call an effective feedback loop, like, okay, I didn't start that project early enough that time. So that means the next time I'm going to make these corrective actions so that I do it differently the next time. That's harder for people with ADHD to kind of use that loop back information. We think about, how to do multi-step directions, having a sense of time. How long does it take things? And that's one of the things that adults who come in often complain about, is that in their work life, one of the things that they struggle with is estimating how long does it really take to do this project. I got assigned this great project, and I said to myself, I've got 6 weeks. It's not going to be any difficulty to do that, but not really judging accurately how long that actually takes. And then one of the other things that Dr. Schweitzer had previously talked about is, that being able to do that emotional modulation, and our understanding that that is an important piece that people with ADHD can struggle with. Being able to tolerate frustration, being able to think before, saying something. And in terms of, kind of an assessment protocol, how do we diagnose ADHD in adulthood? In many ways, it's very similar to how we do it with kids, which is that we want to do a good clinical interview with the person. Ideally, to make observations if those are available. Sometimes that's difficult to do. But we also want to make sure that we're getting what we call collaborative information. That is, we want to be able to interview parents or a spouse or a partner, because people with ADHD often have a hard time assessing their own symptoms or how they are doing, and being able to get that collaborative information is really helpful, both in making a good diagnosis, but also maybe perhaps ruling out what could be, a different condition. So we certainly use, in addition to interviews, perhaps some rating scales, both, certainly from current ones, retrospective ones, ones from parents. Ideally, it's great if we can get things from teachers, and certainly previous records, report cards, other job evaluations, things like that, that help to build kind of, a better clinical picture of what's going on. In terms of treatment, and Dr. Pakyurek will talk more about this, so we certainly know that pharmacotherapy helps to treat what we think of as the core symptoms, and the core symptoms being the inattention and the distractibility. But ADHD is one of those conditions that needs what we consider to be like a multitude of treatments. So in addition to pharmacotherapy, we also think about social and behavioral interventions. And one that's gaining more data in terms of its efficacy is something that we refer to as cognitive behavioral therapy, or CBT, which really helps adults with, kind of their thought patterns, how their thoughts and behaviors go together, dealing with distorted thinking, dealing with things like thinking like, okay, I'm really rotten at this and nobody else is struggling with this and this is really unfair, and having a therapy that sort of begins to address that sort of thinking as a part of the treatment pattern. And we certainly know we have many years of research in terms of the efficacy of CBT and its helpfulness with anxiety and depression, which are often the co-occurring conditions. There is some evidence that things like CBT can reduce medication dose or may help to increase the effectiveness of medication. There is ADHD coaching, which is often helpful just in managing the day-to-day pieces of people's lives. And there's also some new research that suggests that the role of mindfulness training might be helpful. There's some research coming out of UCLA where they actually have a program, I believe it's the mindfulness something program. There's an A, and I forget what the A stands for, but it's the MAP program, and it's the ADHD MAP program actually at UCLA. And those are all important because California has some of the lowest rates of stimulant prescribing in the nation. And occupational suggestions, and these are really tiny, and so now that I'm wearing my glasses, let's hope that I can actually read them. So one of the things that Dr. Schweitzer mentioned is that it's important in terms of work life to think about what certainly where challenges might be, but also where are things that might be helpful. And certainly one of the things that is helpful in terms of occupational success for people with ADHD is having a job that has novelty, where perhaps maybe you're not sitting at a desk all day, where there's an opportunity, to literally physically move around, but also to be able to shift set and to be able to do a number of different things.
Hi, everyone. Can you hear me okay? I'm going to thank two of our fellows, Dr. Bedford and Dr. Collins. They were one of them graduated. He's now a faculty at University of North Carolina, and Dr. Collins is a current fellow, and they are responsible for most of these slides. So unfortunately for you, they are better presenters than I am. So we'll talk about the history of ADHD very briefly. It will be a fun, brief review. We'll talk about the basics of ADHD because we have to. We'll talk about the treatment of ADHD in adults. I'll give you an overview. And finally, relevant new research. Around 1580, 1590, Shakespeare talked about ADHD in one of his characters in Henry IV. And he said for John Falstaff, he talked about having the disease of not listening, the malady of not marking. It's pretty amazing. And then it turns out 1775 was a great year for ADHD. We have a German physician and a Scottish physician, and they both differently observed people who cannot pay attention, who cannot sit still. And if you look at the Sir Crichton's description, it's pretty fascinating how careful he was in his observation, and toward the end he says, what is very fortunate, it's generally diminished with age. If you look at the 20th century nomenclature on ADHD, you will see various terms, right, including defective moral control, organic dryness, You'll hear minimal brain dysfunction. There are still physicians and other providers, by the way, use some of these terms. Hyperkinetic child syndrome, and finally, ADD, or attention deficit disorder. I won't spend much time on this. Dr. Schweitzer and Dr. Dixon did talk about this briefly, but we have the genetic factors and environmental factors. If you look at the environmental factors, you will see items such as exposure, postnatal exposure to lead, and low oxygen states. Dr. Schweitzer briefly talked about this. I still hear this every week in my clinic. So is ADHD real, doctor? There are several reasons that we should probably consider it is. Because of the genetic background, structural brain differences, again, Julie talked about that a little bit, long and consistent history. We have the presence across cultures in many different continents. We have the diagnostic validity, and similarities but differences in outcomes over time may or may not be related to the treatment. We'll talk about comorbidities briefly. This is from Dr. Jansen, modified slightly. I use this slide because I think it's so clear and it captures some of the important elements, certainly not all the comorbid features. You'll see here huge conduct disorder plus oppositional defiant disorder. And it will be really important. It will have some relevance for people's choices in the future. Significant chunk there, anxiety disorder and others. What are those others? Increased risk for suicide, both attempts and ideation. Why is that important? Because if there's comorbidity with depression, for example, you really have to monitor the individuals that you're working with for suicidality very carefully. Increased alcohol, marijuana, and nicotine, and earlier use of these three items. If there is ADHD plus conduct disorder, you also have increased risk for use of hard drugs, cocaine and everything else. So we have to be really mindful about the comorbidities. Now, bipolar disorder is very interesting, and I know some of you are very familiar with this. If you have bipolar disorder, you have a very high risk of having ADHD. Depending on the studies, it goes from 30 to 65, 70%, some US, some European studies. But if you have, it's almost one-way street. If you have ADHD initially and you're looking for bipolar disorder in that population, it appears to be lower. And certainly autism spectrum disorder, now we have DSM-5, and we can diagnose those two conditions separately. This is, I'm not going to spend much time on this because Dr. Dixon did a fantastic job with her fancier slide than mine, but I think this is a pretty nice slide too. It gives you a nice lifespan approach and some of the difficulties starting from birth all the way to the adulthood. This is from, this slide is from Dr. Collins, adapted from Schmidt. Psychiatric assessment of ADHD, previous presenters really talk about this, so I won't spend much time, but we have to be careful. If there is significant medical concerns, it's okay to order certain labs. And there are some studies that we're trying to get one started too, that looking into metals and both ADHD and ASD. This is the multimodal treatment of ADHD. Again, the previous presenters talked about this, but you have the biological treatment and medications. You have school-based or workplace-based supports. They are just as important. We have behavioral therapy options. And finally, additional treatments, not alternative, but complementary treatments. Is everybody with me still? We're doing okay? Great. Medications, this is from Barkley. It's a fun slide. It's a very simple but very inclusive slide that I like to use it because it sort of summarizes the stimulant story for you. Stimulants and non-stimulants, methylphenidate and amphetamines, and if you look at the stimulants, it will be duration of action, very simple, short or long, right? It's pretty simple, pretty basic, but it really explains. Non-stimulants, there aren't many of those either. You have the norepinephrine reuptake inhibitors, such as atomoxetine. We have the alpha agonists. We'll talk about those briefly. And very old, but still valuable for a subgroup of patients, TCAs or tricyclics. This is a stimulant medication table. If you look at I included some commercial names here because they may have the same active substance, but they will have completely different delivery systems. Two medications may have the same active substance, completely different delivery, one from 1950s, one from 1990s. So it's important for you to realize that. And sometimes it's okay to argue with your pharmacist or the plan if they are pushing you for an older technology for delivery, because the side effects appear to be much better in newer, more consistent technologies. Short-acting stimulants are less used these days. We, for the most part, start with longer-acting stimulants and maintain the treatment with that, but short-acting stimulants may have a place in treatment. Mostly for sensitive individuals, or we can have some brief trials sometimes. There is a group, they are longer acting stimulants, but we call them intermediate really because they are shorter acting than much longer acting options, and they seem to have dual pulse. So they have this biphasic appearance. Right in the middle of the day, around noon, the blood level will go down, and some parents feel that it helps with the kid's appetite. This applies to adults as well during the lunchtime. So it may be a valuable tool because they are not as long acting. If there is a sleep issue related to stimulants, they leave system earlier, they may be reasonable as well. Most of the patients, though, will require long-acting stimulant medications for best outcome in terms of medication treatment. I will very briefly touch upon the common side effects. Most of them will be mild and temporary. However, if you keep stopping the medication every third, every fourth day, or every weekend, the side effects will return when you go back on the medication, as if you are taking it for the first time. Does it make sense? Atomoxetine, very briefly, it's the first non-stimulant approved by FDA for treatment of ADHD. It may be a really good choice for maintaining a 24-hour blood level for individuals with comorbid anxiety and tic disorder. Be careful, it may cause some liver injury, so it may be reasonable to monitor the enzymes. Non-stimulants, these are interesting group of medications, centrally acting alpha agonists. There are only two of them, guanfacine and clonidine, and of course, extended release options. Extended release options are great. Why? Because they don't have this rebound increase in blood pressure when you forget to take the medication. I remember I had a patient, wonderful family, trip to Hawaii, they forgot to take their medication with the boy, young man, ended up in emergency department because of the significant increase with the blood pressure. Now, that is especially with short-acting clonidine there. Happens less with guanfacine. With extended release options, you're not likely to see that sort of dramatic rebound effect. Guanfacine extended release appears to be a really good medication, well studied in children and adults now, but the dose requirements may be higher than initially thought to make a difference with executive function and the impulsivity. I love this slide because it's a scorecard for the main medications. 1 to 10, methylphenidate gets an 8, not bad. Strattera, 6.5. Clonidine and guanfacine, they are both close to 6. And we have a complementary item there, omega-3. Turns out that it scores higher than placebo. And we'll talk about complementary strategies more later. This is a special population I want to bring up because preschool age children can be treated with medications, but we have to be very careful with the comorbidities, and the dosage needs to be really very carefully fine-tuned, and the lower the better in our experience. Adults. Now, this is going to be fun because there are wonderful new studies around the world. Look at the long-standing patterns. We have patients, we have a recent patient from the Bay Area. She showed up for the initial visit with years of teacher reports and comments, these teachers writing about, from elementary school, about her being so brilliant yet having all these problems, sitting still and waiting for her turn. That is really helpful to us diagnostically. So keep those old records. Comorbid conditions need to be addressed, and they are very common in adults. Anxiety, substance issues, depression, bipolar disorder. Unless you work with those issues and address them, your ADHD treatment with the stimulant medication alone will likely to fail. It won't be successful. Adult checklists are very helpful. Dr. Schweitzer talked about this. And vocational support is just like 504 or IEP for children. It can be crucial, needs to be utilized if available. All right. This is we'll talk about the medication treatment for adults in ADHD with some new studies. One of them is very recent from Schweitzer, and they looked at methylphenidate versus placebo in adults. These are 25 and up. It's an older age group, and the response rate was 76%, 19 of placebo. That's a really very significant success, and it wasn't really so much dependent on the socioeconomic status or the gender of the patient or even comorbid condition. That's hopeful. Saffron study looked into medication plus cognitive behavior therapy. The previous presenters talked about CBT a little bit. Dr. Dixon mentioned that. And it appears that when you add CBT, indeed, it lowers anxiety symptoms and other comorbid issues such as depression. It's important to take advantage of that individual therapy along with the stimulant medication. Finally, they looked at Willen's group, Tim Willen's group looked at the atomoxetine in adults with chronic alcohol issues, and ADHD symptoms really improved in the study, but it turns out that the alcohol use behavior did not improve as consistently. There was a discrepancy in the response. This is a very recent study as well, and in this particular study, they compare methylphenidate or Ritalin with atomoxetine. And both groups in adults did very well. They both responded to the medication. Most of them tolerated the treatment. Dropout rate in the study was quite low, and there was not much difference in terms of the adverse effects in these two groups. Group treatment for adults with ADHD, this is from like Dr. Schweitzer, one of her slides, it was wonderful. This is from last week, I think, so it's a they just published this. It's very recent and it's very, I thought, creative program. It's a group treatment for adults with ADHD. It's a 14-week long program, and they use CBT plus DBT, so cognitive behavior therapy plus dialectical behavior therapy, and it was weekly groups. And then they did 1 month and 6 months after the group was concluded, they looked at the ADHD core symptoms. And the group did great. People who participated in this 14-week program did very well and remained stable with minimal symptoms at 6 months after the study. That's really encouraging for us to maybe think outside the box a little bit and look into new options in addition to medication treatment. Depression and anxiety symptoms have also improved in the group as a whole. Complementary treatments, very briefly, I'll talk about two of them. One of them is exercise. Michael Phelps talked about how exercise, excessive swimming, and exercising 9 hours a day helped him with his ADHD publicly. Again, it turns out he was right. We think this is happening because there's a significant increase with BDNF, which helps with the central nervous system growth. It helps with synapse and a nerve formation. as well as some other mechanisms. So we are thinking that these are the important factors, but this may be one of the safer complementary strategies. Please do not overlook keeping those individuals active. By the way, high BMI, overweight status is a significant problem in adults and adolescents with ADHD. So this is another great reason for us to consider this as probably the main complementary strategy. Omega-3, again, it turns out it's better than initially thought. If you look at the meta-analysis of, a beta-analysis of 10 studies, it scored about 31, that 1 to 100 scorecard I talked about earlier, did better than placebo, and it appears to have some benefit, not instead of treatment, again, additional benefit to the existing treatment strategies. Few relevant new, but I feel important new research. I get this question all the time, both from adult and younger patients and their families. Do stimulants cause tics? They make it worse, and what can we do about that? The studies about the FDA warning about the tics and stimulants are case report based, individual case based from 1970s. The recent studies, including TACT study, show that they looked at the methylphenidate, clonidine, and the placebo group. And out of the three groups, actually the methylphenidate group did better than the other two, including clonidine, by the way, is one of the treatment strategies to address tic disorders. So that's very hopeful. And they looked at the 22 randomized studies, and they did not see any association between new onset or worsening of tics. So you may have individual stories, but if you look at the large trials as a whole, it doesn't seem to support that. And there was no difference between methylphenidate or Ritalin and amphetamine salts, which is Adderall group. So they were just the same. If tics emerge with stimulant medication in individual patients, despite all this data we have, trying another stimulant medication may be a good option initially, and then if it's happening, try a non-stimulant medication strategy. The second nice new research that I like, they looked at the childhood ADHD research group from childhood, and they did a follow-up study for these same individuals as adults, and they looked at their achievement scores. And these are individuals without specific learning disorders, so they have general ADHD. 10 years later, they looked at their achievement scores, and of course, they found that they had significant underachievement in both reading and math scores. And they feel that this explains both occupational and personal difficulties, or may help explain. This is interesting because we are looking at adult studies long-term. Now, ADHD studies are very different from depression, anxiety, psychosis, and bipolar disorder studies. In ADHD, we have larger data in children and adolescents, really much more limited data in adults that we are just starting to look into. With all other psychiatric conditions, it goes the other way. We have plenty of adult data. We're just starting to look into the children, pediatric data, I should say. ADHD and sleep regulation, another, just like high BMI, another under-addressed issue, in my opinion. People with ADHD, it turns out, have a lot of sleep regulation problems. Some of them may be feeling very tired right now and bored and falling asleep. You're not alone. There is an excessive daytime sleepiness or sedation at moderate or severe level in ADHD population as well, and it's very high. It's significant, and it affects their treatment response, their day-to-day functioning, and even their driving, according to this study. It's really significant. And by the way, if you talk to clinicians who work with individuals with ADHD, they will tell you about the excessive daytime sleepiness or sedation issues. But now it's published, and there's some studies supporting it. I thought this was really interesting. And finally, they talk about addressed issues, pregnant women and ADHD in this group. Very limited information. They looked at the ADHD symptoms in this group and self-reported, and they looked at the occupational or professional relationship and finally daily functioning scores. Now, they did this with depression, they did this with anxiety, but nothing, if you look at the pregnancy and ADHD, its impact, there was nothing up to this point other than case reports. So this is really significant. And they found out that there is indeed a significant association between having ADHD and level of functioning and difficulties in women who are pregnant. Inattentive symptoms, you'll see at the bottom, inattentive symptoms were significant predictors of professional life impairment, daily life impairment, and relationship. And the impulsivity uniquely predicted variability in professional life impairment, as well as personal relationship impairment. I think it's very important for us to pay attention and address the issues in this population. Again, this is a population that we rarely discuss ADHD with.
So as all of you, I'm sure, know, people with ADHD, we are off or we are on. We are awake and up, or we are asleep and slow and behind. This is really exciting to me to see that there is documentation, that there's a study showing that this isn't just us being too sleepy. It's not something that we're not trying hard enough, that it's seen across other people with ADHD. I am a very, very lucky person to have support from family, friends, colleagues, neighbors, community. And I wouldn't be able to be here and be as successful in my life as I am without the kind of supports that the three doctors have spoken about. I have a treatment plan that encompasses psychiatry, psychology, counseling, exercise. I monitor my diet. I also have opportunities to express myself through art and poetry. And all of these kinds of things are what allow me to have my personality come out without the hindrances so much of my diagnosis. So this whole set of support that has been talked about tonight, I want to share a few specific things that might be helpful for you, as either things that if you yourself have ADHD, you could share with other people around you, or if you are treating or supporting someone else with ADHD, that you could also learn that might be helpful for your loved ones or your patients to know. So in terms of deciding to commit to treatment, I was very fortunate growing up to have supportive family. I did not have treatment at all other than the support of my family and school. School was really helpful, having short classes, just like Dr. Schweitzer and Dr. Dixon were speaking about. When you get to college, all of a sudden you have these really long classes and have to decide what you're going to do with your time, and that's when we started getting really serious about what are we going to do, why did I go from straight A's to failing, how come I don't know how to decide when I'm going to go to sleep or when I'm going to do my homework or any of that. Everything kind of fell apart. So it was in college that's just kind of learning and understanding, but I didn't really start treatment until after I'd already dropped out of Georgetown. And I want to say about academics, right here in Sacramento, Cal State Sacramento has an office for services with students with disabilities that when I was ready to go back to school was incredibly helpful. I highly recommend connecting people with ADHD to that school. They have a high-tech center which utilizes these new technologies to help us get through, and also it helped alleviate several symptoms because I learned how to use technology and use tools and use support of my peers to be able to rise to what my capacity is, which is actually really great. We often hear all these negative things about us, and I want to share a little bit about that too. We put even supportive people, but we hear all around us, especially as we age, a hyperactive female in her 30s is not as acceptable as a small boy who is able to run outside and play. So I hear things like, calm down, slow down, stop being so hyper, you're too energetic, you have too much energy, you're too happy. All these things hurt after a while. So having the "to" in front of all of these statements, I recommend to everybody to stop and think, like, is it something that's actually negatively impacting you? Is someone's high energy actually a problem for you? And if so, say why. Like, when I come home and you're so, and you have so much energy, it makes me feel like blah, blah, blah. Try to express what you're actually trying to say instead of just labeling you're to this or to that. So that's another little pointer. The driving situation is really serious. When I get into a car, I know that I am in control of a huge vehicle. Well, it's not huge, but it's a piece of machinery that someone else's life, my life of course, but someone else's life could be in danger. We have a great bus system here. I take it. If I wake up and I'm getting ready for work and I'm like, you know what, the medication hasn't kicked in yet, I don't know, something's off, I take the bus or I walk, and please, all it takes is once to be distracted and cause something really serious for your own life and other people's. So please take the bus or find other ways to get to work. Let's see. I guess, so please make sure that we know that we accept each other's differences. We don't all have to be the same. We don't all have to, like, maybe someone with ADHD might say to you all, well, you're too predictable. Why are you sitting there so calmly, you know? Why don't you have more energy? And actually some of the things that I feel about things I hear is like, why aren't you more excited? When I hear slow down, sometimes I just want to say I'd rather run away. When I'm told to shush because I'm talking, I feel like need to try harder to dissolve. So depression and anxiety are really real with people with ADHD because we're constantly letting people down. And the thing we hear the most is just try harder, just try harder. Look, we're trying really, really hard. We're just different. So I really enjoyed seeing the suggestions, the occupational suggestions also. Those were great, and those are things that my treatment team has helped me with here as well. I think that's, yeah, sure.
So the first question I have here is, does stopping then restarting medication decrease its effectiveness? It probably does, and it also increases the risk of having side effects every time you go back on the medication. There will be clinicians recommending weekend breaks or summer breaks or Christmas breaks for the medication treatment. With all the research you heard here, the comorbid conditions, the driving risk, all other impulsive issues, the life doesn't stop just because the school is out Friday afternoon, right? The weekends, especially the term of quality time with your family is so important. But also chemically and receptor-wise, you may make some changes. It may lead to some changes. So I would say, please, if you feel that the medication treatment is for you and it's helpful, it's important to stay on the medication on a very consistent basis. Very quickly, the second question is about cardiovascular risk in middle-aged or older patients with stimulant medications. Stimulant medications can certainly increase blood pressure, especially at the beginning of treatment. So individuals with cardiovascular problems can take stimulant medications. It's not a contraindication, but it has to be closely supervised. You have to have your EKG, you have to have the regular monitoring, and probably smaller doses and gentler medications over shorter acting and higher dose application of medication treatment. Thank you.
Okay, this is a great question. How definitive are MRI-detected changes in pinpointing an organic etiology in adults diagnosed with ADHD? This is a wonderful question because we see a lot about not just MRI, other imaging technologies in regard to diagnosis, not just in children, and not just in adults, but in children as well. At this point, we don't use any of the imaging technologies for diagnostic purposes. We use them for research purposes only. We tend to look at the images in groups and average them together so we can better understand ADHD as well as treatments for it. But at this point, they are not diagnostic. And if anybody encourages you to be seen by their clinic and so forth and charge you for that, that is not recommended, but not just by us, but also the National Institutes of Mental Health, NIMH. If you go to their website, they clearly state that on their website as well. Now, there are times when you can have some organic reasons for why there are problems in brain functioning. And there are certainly other situations or organic situations that can mimic ADHD, but that's highly unusual. So that's and at that point, certainly with your physician, that should be discussed. Usually that's something that's a very sudden onset. And Dr. Packer, I don't know if there's anything else you'd like to add to that.
One comment. There's some recent studies from Europe and I think limited from North America. They talk about the EEG, much cheaper than imaging studies, as you know, but certain suppression pattern in EEG and its diagnostic value in ADHD. It's very promising because we do EEG all the time for various reasons, and this pattern in combination with clinical observation appears to increase the recognition and diagnostic value of the assessment. So that's something for us to be hopeful moving forward.
Right. So that's a long-term goal for many of us. But at this point, there are also many times when somebody can walk in the clinic and we can do a good diagnostic assessment, and the MRI or EEG doesn't add any value to it. And it does take a lot of time in terms of processing the information if it's done right. So we also have a question here about enrolling in any treatment studies. We do actually have a number of treatment studies right now. They're for children. At some point, we do have one actually, I take that back, for from 12 to age 30 that will be starting re-enrolling again. So we put that on hiatus, but that will begin. That's more actually understanding mechanism of action. So it's not treatment in the sense that we see whether a treatment works, but we're trying to understand better how medication in ADHD works. But we do have a number of studies right now, if I might take the opportunity, for 8 to 12-year-olds where we're using technology to look at its effects in terms of ADHD. And those are some fun studies. If you look at our website, you can see those studies. And we are also... Yes, and we are still, we're doing another study where we're looking at brain development in ADHD from age 12 to 25 or so. So that's not a treatment study, but that's looking at how we see brain changes in development and how it's associated with self-control, academic achievement, and other functions. We have some questions down here.
One of the questions was, where can I find a resource list for CBT and coaching? And actually, I have some cards here, and Terry would be able to give you my email, and I can email you out some of the resources in the area, which unfortunately are not as robust and numerous as we would like, but there are some sources out there that we might be able to pass on to you.
So there's a question, is it true that females tend to not have hyperactivity in ADHD? And I also have many friends who are very hyperactive, and a lot of it when they're able to channel it as mothers. So it matches their ability, the needs of them as being a mom. I'm not a mom, so I spend a lot of time climbing things and building things. And also I find that with the males I know who are 30 and older with ADHD, I see, from my experience, I see fewer hyperactivity symptoms in males. I'm kind of like, come on guys, let's get going here. So I have it scientifically.
Right, I was going to say, yeah, so I wanted to talk just a little bit more about that. And part of that has to do with that developmental progression, is that at younger ages, we often see more of the hyperactivity, impulsivity in boys, not so much because it doesn't exist in girls, but because it gets recognized first in elementary school, in first and second, grade, there perhaps might be a concern. But so when you think about it developmentally, it's a symptom that gets noticed sooner than perhaps the quiet, inattentive symptom.
Question, can you please let us know what technology helped in college? Do you use any of that technology at work? There are two main things that were extremely helpful. Three. One is the audio recorder, just a basic audio recorder. Now, I used to use the little one that was a little cassette because they didn't have the digital ones when I went through school. But they have digital ones now that people can plug into their computers. There's a really neat pen that's called, put out by LiveScribe. Are you familiar with it? Okay, so it writes. Okay, while you're writing with it, it records the audio, and you write on a special piece of paper, and it records what you're writing, so you can look at it back on your computer, play it at a different speed, and see your own handwriting writing, and hear what the professor or whomever was saying. It's really helpful, incredibly helpful. Then the other thing is at Cal State Sacramento's High Tech Center, they have a program called Kurzweil 3000. I graduated in 2009, summa cum laude, by the way, so that means straight A's. And that program is probably 4,000 now or 5,000, whatever it is. I would bring my books in ahead of time before the semester started. Very important too, because previously this class would be halfway over and I hadn't even figured out what books to buy yet. So this helped keep me on task, but to purchase the books ahead of time, bring them in the summer or in the winter. They would scan the books in, they would unbind them, scan them in, and then I would be able to put them on an audio CD and watch also, watch as it was reading it out loud, the speed set by phrase, etc. So I really was able to understand the material a lot more, and with that extra, the audio and sight, I got to pay much more attention to it. It was fantastic. So those are a few very helpful things.
I have to say, I'm very excited about the era of technology. It can be used for good or for bad, as we all know. The bad can be that's really tempting, I think, to look at other things and get distracted. But I think that there's a whole new world out there. And people with ADHD, I find oftentimes, can be more visual learners. And so to think about how information can be presented visually as well as verbally and auditorily. But also I would recommend, for people who are in college, to ask their instructors for their slides or whatever materials that they use for their teaching, because as I find people are much more open now about sharing their materials that they use for their teaching, and I think that can be also really helpful. So I'm just really excited to see how people can use it more in the future. A couple other questions here. A question about why California has lower rate of prescribing for medication than other states. That's a really interesting question, and I think there's many reasons for that. I don't have any data to support some of these ideas of mine, but some of it I think is simply has to do with our availability, that we have more resources in California than some other states have. I've lived in several states in the country, and we wish we had more resources, but in terms of that, I'm thinking about mental health workers, other professionals who recognize ADHD and have opportunities to provide treatment. Many other states have much more limits in terms of that area. Also, I think people are willing to try other approaches besides medication in California. I also wonder if it might also relate to our ethnic groups and so forth in California. So we have a high rate of groups that are less comfortable seeking out help. So it might not be that there is lower rates of ADHD. We certainly don't have any evidence of that, but I do think that there are people who might be less comfortable seeking out help from mental health professionals and particularly using medication for those challenges as well. There hasn't been much work done in that area, but I'm hoping that we'll see some in the future. One of the questions is about lead in the environment. There's a long history that we know about lead causing not just ADHD, also impacting intellectual functioning and so forth. We've seen the reports, I'm sure many of you have, from Flint, Michigan, and what's happening there. There's also some other reports looking at environmental factors, and I'm very proud that we are one of over 30 sites within the country to be part of something called ECHO, which is a study funded by the National Institutes of Health, where we will be looking at the effect of factors within the environment and how it affects neurodevelopmental functioning. And our team here at UC Davis, this is a project led by Irva Hertz-Pachotto and Deborah Bennett and myself, will be looking at specifically what factors in the environment, phthalates, how close you are to the freeway, nutrition factors, lots of different factors, how that affects development in children over time. And we're specifically looking at ADHD symptoms as well as autism and so forth. So to be continued, but there's growing evidence out there that there are some suggestions that the environment can lead to changes in terms of brain functioning and so forth. Let's see. There's a question here about cognitive behavior therapy and DBT, dialectical behavior therapy, can treat PTSD. And that's not my area, but I can tell you CBT has a long history of showing efficacy in post-traumatic stress disorder. So I can say definitively, yes, there's some great studies in that. And I'm assuming the same for dialectical behavior therapy. What about this one?
The question is, how do you know if you have ADHD? That's a great question, and it really depends on the developmental phase. It's very different from a young adult, from somebody who is in preschool years. Sometimes it is impulsivity, sometimes it's the hyperactivity, and sometimes it's the executive function and the processing difficulties. In our diagnoses, it's wonderful to hear the story from the patient or the family, but it's also great to get supportive checklists from others. It can be another adult involved in the life. It can be teachers, and it can be caregivers of any kind. When you have suspicion, you feel that you are academically and socially underperforming, or you're professionally feeling stuck, that things are changing, it may be reasonable for you to discuss with your primary care provider just to get their insight and observation and then take it from there. Alice, you may have some comments on this question too.
I do. Actually, I think one of the most important things is to look at the impact on your life, because if you have ADHD and you're functioning just fine and dandy, there's no need to seek treatment if you are happy and satisfied in your life. I know several people who've also tried medication treatment later in life when they learned about ADHD and suddenly were like, oh, that explains so much, and they had the report cards, they had everything to show that they truly had ADHD or have ADHD, and then have chosen, after trying medication treatment for several years, that wasn't right. They didn't like how it felt, but they've continued on with the psychology and counseling and the other supportive treatments. So I think that's the biggest thing to me. I try to tell people who are like, I think I might have ADHD, don't jump to the conclusion that you need medication or need to change anything, but awareness of it might be helpful. But if you're doing well, keep doing what you're doing.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.